My name is Pat Macarella-Hafey, and I'm the Director of Education here at HIA. Thank you for your interest in our ICD-10 education series. Our education series was developed by myself and Beth Martillick, Assistant Director of Education here at HIA. Together, we have extensive experience in the HIM and coding industry to include supervision, auditing, and coder education. Collectively, we have over 60 years experience in coding education. Since our founding in 1992, we have reviewed the coding of nearly 1 million medical records for well over 700 clients. We see trends and where coders struggle the most. We have incorporated those areas into our ICD-10 education series. Having worked with coders for over 30 years, I know how a coder thinks, how they process record information, and what to present to maximize their learning. Our modules are AHIMA approved and are designed for the experienced coder who wants to know how ICD-10 is going to be different from ICD-9. We review the ICD-10 code structure, the guidelines, and how to apply the ICD-10 codes. The modules and reference materials can be accessed on demand on HIA Learn. HIA Learn houses a comprehensive coding education library. We have developed our education series into a three-part process. The first part is a 150-question anatomy and physiology assessment, and it truly is an assessment rather than a test. It assesses the coder's proficiency not so much in what they need to know for ICD-9 coding, but what they will need to know for ICD-10 coding. The coder can use the results to further structure their anatomy and physiology self-study. Management can review the detailed report to ascertain a coder's proficiency. The report provides individual and collective results by coder for each question, a summary of results, and a graph that depicts errors by body system. Which brings us to the second part of the process, the ICD-10 education modules. There are 35 education modules, 16 in ICD-10-CM and 19 in ICD-10 PCS, and all of them are organized by body system or PCS section. That is 70 hours of education. Within each module, we follow a consistent pattern. First, we discuss the main differences between ICD-9 and ICD-10. Next, we present the official guidelines for ICD-10 as they relate to the body system. Following that, we present an anatomy refresher that is focused on ICD-10. Finally, we discuss relevant clinical indicators related to body system diagnoses. For both ICD-10-CM and PCS, we have case scenarios throughout the modules that the coder completes to reinforce concepts and guidelines presented. For ICD-10-CM, we have a 20-question quiz at the end of the module, and these are AAPC approved. For ICD-10-PCS, we utilize 2 to 4 actual hospital operative notes and ask the coder to complete the coding. We then review the answers and rationale so the coder can check their work and learn from their mistakes. The final part of the process will be a 100-question ICD-10 coding assessment that incorporates all of the module content to evaluate competency. Now you're going to see a selection from 2 of our modules. The first excerpt is from the ICD-10-CM circulatory system. The topic is myocardial infarction. This is an area where the rules and guidelines have changed significantly. The changes for myocardial infarction coding in ICD-10 are significant. This slide shows a summary of some of the changes in MI coding. For example, the period defined for an acute MI has changed between ICD-9 and ICD-10. In ICD-9, the period was defined as 8 weeks, and now for ICD-10, it's defined as 4 weeks. Patients having had an MI between 4 and 8 weeks will be coded as having an acute MI in ICD-9. However, in ICD-10, this is going to be coded as an old MI. The use of the word subsequent in the MI classification has also changed. For ICD-10, no distinction is made for subsequent episodes of care. All episodes of care for treatment of an acute MI within the 4-week period are coded to acute MI codes. Subsequent MI is used to classify a new acute MI occurring within the 4-week period of another MI. A number of cases currently classified in ICD-9-CM as a subsequent episode of care will be either classified as an acute MI, which is within the first 4 weeks, or an old MI case in ICD-10-CM, which is between weeks 5 and 8 in ICD-9. In ICD-10-CM, we have 2 main category codes for MI coding. Category I-21 for ST and non-ST elevation MIs, and category code I-22 for subsequent ST elevation or non-ST elevation MIs. In ICD-9-CM, there were 10 codes for MI coding, and as you know, these included 5th digits. In ICD-10-CM, we now have 14 codes that delineate which coronary artery is involved and the area of infarction. For example, the coder will now need to know whether the main coronary, the LAD, the circumflex, right coronary, etc., is involved within the myocardial infarction. MIs can be a coronary occlusive AMI, where there is death of myocardial fibers distal to the point of occlusion. If a tiny vessel is blocked, it's called a non-ST elevation MI. If a larger vessel is blocked, it may be a Q-wave MI or ST elevation MI. These are coded by site in ICD-10. A demand MI is a situation where one cell here and one cell there has died, and you can't find any EKG evidence. This is why some of the MIs are not on the EKG report. For our category I-21 MI coding, please refer to your handout, the official coding guidelines for reporting, and look at section 1C 9E. If a non-ST elevation MI evolves to a ST elevation MI, the coder will only assign the ST elevation MI code. If the ST elevation MI converts to a non-ST elevation MI due to thrombolytic therapy, the coder still assigns the code for the ST elevation MI. The category code I-21 code is used up to 4 weeks, that's 28 days, as long as the MI is still being treated. After 4 weeks, or 28 days, the code I-21 cannot be used for continued care for the original MI. You must now use the aftercare code. Otherwise, code I-25.2 for old MI is used for an old or healing MI not requiring further care. For any post-myocardial infarction syndrome, see code I-24.1. For a subsequent MI occurring within 4 weeks of an initial MI, see category I-22. Category code I-22 is for subsequent MI coding. Again, we have subcategories to delineate ST elevation MIs and non-ST elevation MIs by site. Category code I-22 includes an acute MI occurring within 4 weeks or 28 days of a previous acute MI regardless of the site. A code from category I-22 must be used in conjunction with a code from I-21. The I-22 code should be sequenced first if it is the reason for the encounter, or it should be sequenced after the I-21 code if the subsequent MI occurs during the encounter for the initial MI. The coding for subsequent MIs can get very confusing. Be sure you are following your official coding guidelines. Category I-22 is never coded alone. For category I-21 ST elevation MI coding, we have had in the past codes for specific wall identification. This wall identification continues for ICD-10-CM in both category I-21 and I-22. For category I-21, physicians will need to start documenting the specific vessel for which the MI has blocked. This is new for ICD-10-CM. This slide shows an example from the tabular for category code I-21. Specifically, this is for the anterior wall ST elevation MI. You can see the detail needed to apply the codes. There are different codes available for left main coronary artery, left anterior descending coronary artery, and the diagonal branch of the coronary artery. There is also a subcategory level code for other coronary artery sites of the anterior wall. You can see how detailed the coder will need to be in assigning subcategory codes for acute MI. If an acute MI is documented as a non-transmural or subendocardial MI, however the site is provided, the coder still assigns a code for the subendocardial acute MI. An example here is the anterior wall subendocardial MI. This is coded to I21.4. This is the same practice that we used in ICD-10 coding. The default for acute MI is I21.3, which is an ST elevation MI of unspecified site. Every effort should be made to obtain the proper documentation for the site and location of the MI. So let's practice what we've learned about MI coding so far with scenario 1. This patient's admitted 6 weeks post-acute anterolateral MI with a subsequent posterior acute MI. Which is the appropriate coding and sequencing for the encounter for the posterior acute MI in ICD-10-CM? Go ahead and pause the session, and when you're ready, I'll reveal the answer. Okay, so the answer to our practice scenario number 1, you should have arrived at 2 codes, I21.29 for the ST elevation MI of the posterior site, and then I25.2 for the old myocardial infarction. For this case, the first MI is coded to I25.2 because it's older than 6 weeks. Remember, we have the 4-week cutoff for acute MI. The second MI becomes the initial MI and is coded to I21.29 as the second MI is posterior. The first anterolateral MI is older than 6 weeks and is coded to an old MI. Now let's practice with scenario 2. This is a 56-year-old female who's being treated for an acute non-ST anterior wall myocardial infarction. She suffered the MI 5 days ago and also has atrial fibrillation. What are the correct diagnosis codes and sequencing for this case scenario? Go ahead and pause the session, and when you're ready with your answers, I'll reveal the answers for you. For case scenario 2, you should have arrived at 2 codes. The first code is I21.4 for your non-ST elevation MI. Remember that the anterior wall does not matter when the MI is a non-ST elevation MI. Code I48.91 is sequenced second for your atrial fibrillation.
For our second demo, you'll be viewing an excerpt from our ICD-10 PCS Heart and Great Vessels module. The topic is root operation bypass as it pertains to the heart and great vessels. An actual operative report is coded as well.
Root operation bypass is defined as making an alternate route of a tubular body part. This is commonly seen with coronary arteries and other peripheral arteries within the heart and great vessels body system. Bypass is coded according to the direction of the flow of the contents of the tubular body part. So for arteries, you assign the flow from away from the heart to the destination of the bypass. The body part value identifies the origin of the bypass, and the qualifier identifies the destination of the bypass, except for the coronaries, which we'll go over in a moment. Please see your PCS guideline B 3.6, both B and C. This slide, I have incorporated the actual definition from PCS for bypass. Again, the definition is altering the route of passage of the contents of a tubular body part. An example of this would be an aortocarotid bypass. The thoracic aorta would be the body part value, and the qualifier would be carotid. We have special rules for coronary artery bypass. For coronary bypass, the coder will need to look at the sites actually bypassed, especially for sequential bypasses. You may have two sites that are bypassed on one coronary artery. This will make a big difference in PCS coding. The body part is actually assigned by coronary artery 1 site, coronary artery 2 sites, 3 sites, or 4 or more sites. This parallels ICD-10 coding. A double bypass means that 2 coronary arteries are bypassed. For example, you may see that the LAD and the RCA are both bypassed. A triple bypass means that 3 of the coronaries are bypassed. This would include the LAD, the RCA, and perhaps the left circumflex artery. A quadruple bypass means that 4 coronary vessels are bypassed. In our example here, we have the LAD, the RCA, the circumflex, and the first diagonal artery of the left anterior descending. Quintuple means 5, so bypasses of more than 5 are classified to the body part character coronaries 4 or more sites. 5 coronary arteries bypassed is actually uncommon. The device character will tell you the type of graft used within the coronary bypass. As you know, these can be autologous, non-autologous tissue substitute, or synthetic substitute. Do you know the difference between autologous and non-autologous? Non-autologous means that it is a tissue graft, but it comes from another human. What would be considered a tissue substitute? This would include engineered tissue or synthetic tissue made from stem cells. Years ago, Gore-Tex graft was used in coronary bypass. This is no longer used that often, however, it would qualify as a tissue substitute. On this slide, we have an actual diagram from a coronary artery cardiac cath lab report. These diagrams can be extremely helpful for coders in assigning bypass graft codes. As you can see in this slide, the proximal right coronary artery has blockage. Many times, physicians use these diagrams to show which coronary arteries were bypassed. For coronary artery bypass surgery, the coder will also have to assign a code for the cardiopulmonary bypass. Cardiopulmonary bypass is found in Section 5, Extracorporeal Assistance and Performance. The coder will assign Root Operation 1 performance because the bypass has completely taken over the heart's pumping action. So for cardiopulmonary bypass, during a coronary artery bypass procedure, the code assigned would be 5A1221Z. This slide shows a photo of the cardiopulmonary bypass process. The bypass machine completely takes over the heart's function. So now we're going to assign codes to an actual CABG operative report. Please refer to Operative Report 1, which you downloaded at the beginning of the module. Go ahead and assign your ICD-10 PCS codes and pause the session. When you're ready, I'll reveal the answers. Okay, for our answer, you should have arrived at 4 PCS codes. The first code, 021209W, is for your coronary artery bypass with autologous venous tissue. You should have assigned fourth character 2 to denote 3 coronary sites. Those sites are the posterolateral branch of the right coronary, the obtuse marginal branch of the circumflex, and the diagonal left anterior descending artery, and that would be the distal part. For this artery, the LAD, the surgeon could not get the lima to reach far enough to the distal part of the LAD, so saphenous vein bypass graft was used to bypass this area. You would also assign code 02100Z9 for the left internal mammary artery bypass to the diagonal branch of the left anterior descending. Of course, in ICD-10 PCS, you now need to code for the harvesting of the saphenous vein graft or any other artery or vein used as a conduit. That code is 06BQ4ZZ. And finally, your cardiac bypass code is 5A1221Z.
At HIA, our purpose is to provide the necessary education to ensure a successful transition into ICD-10 coding. We believe our program is an effective tool to achieve this goal. Please contact Health Information Associates for more information on our complete online coding education library.